All right, good morning, everyone. Morning, everyone, and welcome to those visiting online as well. My name is Derek Rutherford, Director in the School of Physiotherapy and representative from our research committee who organizes these PT Matters sessions. So it's a pretty exciting day today for us where we have, once a year, we have our PT Matters sessions as student presentations from the students from the School of Physiotherapy. So it's a pretty exciting day where we have a PhD student, masters in our rehabilitation research programs, and our PT student, our graduate students in our physiotherapy program presenting today. So before I begin, I want to start with a land acknowledgement where Dalhousie University operates on the unceded territories of the Mi'kmaq, Wolastoqey, and Pasco-Makati peoples. These sovereign nations hold inherent rights as the original peoples of these lands, and we each carry collective obligations under the Peace and Friendship Treaties. Section 35 of the Constitution Act 1982 recognizes and affirms Aboriginal and treaty rights in Canada. We recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched that part of Mi'kmaq known as Nova Scotia for over 400 years. All right, welcome back, everybody, and welcome to the final presentation in today's PT Matters session. I'm happy to welcome Madeline Shivgulam. Did I get that kind of right? Almost right. So I'm interested in hearing how it's actually pronounced, and then I'll change it for next time. Characterizing posture in long-term care and in relation to habitual postures with frailty. Madeline is a PhD student with Dr. Olga Theou, a faculty member in the School of Physiotherapy. Welcome, Madeline. I'm looking forward to hearing your presentation.
Thank you so much. All right, I'm going to try and clip this. Can you guys hear me? Yeah. Okay. Well, hello everyone, and thank you so much for having me. Thank you for that introduction. I'm going to get right into it. So, frailty, or the outcome associated with physiological aging, disproportionately impacts older adults living in long-term care compared to those who reside in the community. Now, physical activity is a really valuable tool in our toolbox that can either manage or mitigate frailty levels. But those who live in long-term care often don't want to or aren't able to engage in physical activity. Now, this is problematic because it's created this landscape where our older adults in long-term care are accumulating roughly 22 hours of their day in these sitting and lying postures. Now, historically, these sitting and lying postures have been characterized under the umbrella term of sedentary time or sedentary behavior. But it's worth noting that these sedentary postures may be very distinct from each other posturally, which begs the question whether there's differences between these sedentary postures, especially when we think about health outcomes. So this line of thinking started way back in the 50s with something called the armchair treatment. So in this figure here, which presents some of those preliminary results, we have cardiac work along the y-axis, and we have the number of days after a patient suffered a myocardial infarction along the x-axis. And what we see is compared to patients who remained in a lying posture following their heart attack, which is displayed here in the green line, those that were mobilized to just a seated position, displayed here in the orangish line, actually had a lower cardiac work, which is some preliminary evidence to suggest that, there might be some differences between this sitting and this lying posture with mobilization to just a sitting position, improving this health outcome. So historically, there hasn't really been a way for us to measure sitting postures versus lying postures in the free living environment, but our team has developed the tri-monitor approach with activity monitors that has allowed us to distinguish between the sitting and the lying posture, and then one step further to distinguish between sitting with bent legs and sitting with straight legs as well. Now, some of our early work in implementing this methodology has demonstrated no association between these distinct sedentary postures and vascular health in young, healthy adults. However, it still remains unclear if these distinct postures are associated with the health outcome of frailty, particularly in an older, sedentary, frail population. So the purpose of this project was to first characterize the time accumulated in both upright and non-upright postures among those who live in long-term care, And then to test the hypothesis that an increased amount of time spent in non-upright postures, and specifically in the lying posture, would be associated with a higher or worse frailty. So to answer our research question, we recruited 42 residents, including 37 females with an average age of 82 years, from Northwood long-term care homes in Nova Scotia across the Bedford and the Halifax locations. Participants were included if they had resided in their long-term care for at least 3 months, they could communicate in English, and they were at least 65 years of age. However, they were excluded if they were unable to provide consent, they were bedridden, or they were allergic to a clear medical adhesive dressing that we use in our methodologies. So participants were first approached within their long-term care home by researchers to undergo the informed consent process. Those who consented then underwent a frailty questionnaire and were equipped with 3 activity monitors that they wore for 3 to 4 days before the researcher returned to the long-term care home to remove these monitors. So frailty was measured using the 65-item Frailty Index questionnaire from the Canadian Longitudinal Study on Aging. This questionnaire measures health deficits including chronic conditions, activities of daily living, self-reported health and mental health, where these deficits are scored from 0 to 1, where 0 is the absence of the deficit and 1 would be the complete deficit. And then these deficits were used to calculate the frailty index, which is calculated using the equation up here on the screen, where it is the ratio of the number of deficits present to the number of deficits measured. Our habitual activity and specific postures were measured using the Active PAL triaxial inclinometer accelerometer. We did this in the tri-monitor configuration I previously alluded to. The thigh monitor in isolation was used to detect overall upright postures such as standing time, stepping time, sit-to-stand transitions, as well as overall non-upright time. And then we implemented the tri-monitor approach to distinguish our specific non-upright postures, where we apply heuristic thresholds to hip and knee angles to distinguish lying versus sitting, and then straight-legged sitting versus bent-legged sitting. So getting into some of our characterization results here, in this figure we're going to have minutes per day along the y-axis, and then different habitual activities that were engaged in by this population along our x. So first we see that very little time is accumulated in stepping by this population, only about 7 minutes per day. There was more time accumulated in standing postures, which was significantly more than stepping. However, participants in long-term care accumulated an overwhelming amount of their time in these non-upright postures. And if we break these non-upright postures down even farther, we see that most of them were spent in this lying posture, with sitting split between knee-bent sitting and straight-legged sitting. It's also worth noting that they engaged in an average of 18 sit-to-stand transitions per day and had an average frailty index of 0.44, which can be interpreted as a severely frail population. So to test our hypothesis, we ran linear regression models controlling for age and body mass index. So in this figure here, we have our different, again, habitual activities along our y, and then we're plotting our beta values. So among our physical activities and postures, we have sit-to-stand transition, steps per day, and standing. And we see an inverse relationship between these activities and frailty, where an increased engagement in sit-to-stand transition, steps per day, and standing was associated with lower or better frailty. But then conversely, we see this positive relationship between non-upright time and frailty, where an increased engagement in non-upright time is associated with higher or worse frailty levels. If we break that non-upright time down even farther, we see that this positive association also existed between specifically lying and frailty. However, there was an inverse relationship between knee-bent sitting and frailty, and there was no association between straight-legged sitting and frailty. Now, I'll draw your attention to some potential limitations on these results. So firstly, sleep time was not distinguished for the purposes of this study. It just wasn't able to be done with the population that we were working with. So you'll notice I'm referring to non-upright time as opposed to sedentary time because we're not able to distinguish that. So the relationship between specifically sedentary time and frailty in this population, wasn't investigated for the purposes of this study. And then this is inherently limited by its cross-sectional study design. We're unable to define causality, but it provides some interesting results to inform an interventional study down the road. Now, overall, we see that most time in this population was spent in these non-upright postures and primarily lying down, with sitting pretty divided between straight-legged sitting and knee-bent sitting. Overall, upright postures and activities and knee-bent sitting was associated with lower or better frailty levels, and total non-upright postures and specifically lying as a posture was associated with higher or worse frailty levels. So this provides some interesting information to inform potential mobilization strategies to be implemented within long-term care settings that should potentially target overall upright time and knee-bent sitting and decrease lying time whenever possible. So I'd like to thank the research assistants that were able to collect this data last summer, as well as our funders and our partners in this project, as well as my supervisors, and you for listening and having me. So thank you so much.